The one or the one. Yeah, yeah. Can you? Yeah, I can hear you. Ready? This is endometrial. An ovulation presents frequently with a miss or menstrual period, followed by breakthrough bleeding at an irregular time in the cycle that is often heavy and prolonged. An ovulation can be caused by pregnancy, PCOS, abnormalities of immaturity of the hypothalamic pituitary ovarian axis, menopause, premature ovarian failure, adequate nutrition, chromosomal abnormalities, thyroid disorder. As ovulation does not occur, the endometrium remains in the follicular phase with high concentration of estradiol. This chronic unopposed exposure um, to estrogen increases the risk of endometrial hyperplasia and cancer. This patient morbid obesity increases the risk further as estrogen has converted to as androgens are converted to estrogen in the peripheral tissue. Endometrial cancer commonly presents with vaginal bleeding in the menopausal patient. These factors, in addition to those seen in this patient, include early menarche, late menopause, exogenous estrogen therapy. Diagnosis is made with endometrial biopsy, and treatment consists of hysterectomy plus chemo or radiation, depending on stage. It's not breast cancer. Breast cancer has similar risk factors as those of endometrial cancer. Both endogenous and exogenous sources of prolonged estrogen exposure, such as early, whatever, all that. However, chronic anovulation has the strongest association with endometrial than breast cancer. And it's not ovarian cancer. Classically presents indolently in older postmenopausal female loss. Risk factors of the development of ovarian cancer include BRCA1, BRCA2, old age, nulliparity, early menarche, late menopause. This patient, chronic anovulation and obesity put her at greater risk for endometrial cancer rather than ovarian cancer. Next.
Okay. 42-year-old, a 45-year-old female comes to the office for a follow-up examination after a routine mammography showed 1 centimeter density in the upper outer quadrant of the left breast. Physical examination, the mass is not palpable. Ultrasonogram shows 1 centimeter hypoechoic mass in the upper outer quadrant of the left breast. Which of the following is the most appropriate next step? Ready?
Ready?
Yes.
So ultrasound guided cord needle biopsy. Breast cancer is the most common non-dermatologic malignancy in women and commonly presents with breast mass, skin or nipple retraction or axillary lymphadenopathy. However, it may also be asymptomatic and diagnosed on screening mammography. As with this patient, risk factors for breast cancer development include exogenous estrogen administration, family history of premenopausal breast cancer, BRCA1, BRCA2, early menarche, late menopausal heredity, obesity, African American, family history of multiple first degree relatives, particularly when the relatives are premenopausal diagnosis. Evaluation of palpable breast mass first involves imaging with either mammography or ultrasound to evaluate whether the palpable mass has features concerning of breast cancer, such as microcalcification, speculated margins. If these features are present on diagnostic or screening imaging, ultrasound guided cord needle biopsy should be performed to obtain a tissue diagnosis. Surgical biopsy may be performed if cord needle biopsy is non-diagnostic or if the lesion will be difficult to assess percutaneously. Treatment of breast cancer depends on clinical stage and may involve surgical resection, chemo, or radiation. It is not MRI of the breast is unlikely to be additional benefit for this patient. She has already had an imaging study that showed the mass concerning from breast malignancy. While MRI may better characterize this mass, it will not determine whether the mass was benign or cancerous. A needle-guided excision or biopsy is not the most appropriate next step in diagnosis. Needle-guided excision or biopsy is a surgical excision of the mass, which is typically reserved for cases in which core needle biopsy is non-diagnostic or for cases in which the lesion is difficult to assess percutaneously. This patient breast lesion is in an accessible area, making core needle biopsy the more um, appropriate choice as it's less invasive option to diagnose the lesion. So wait, they haven't diagnosed that the lesion is cancerous yet, so that's why they do the core needle biopsy, or is to remove the lesion already.
Like ultrasonogram give you a clue, but
Hello?
yes, can
Oh,
you hear me? Hello?
yeah, now.
Okay.
Yeah,
I don't,
I can hear you now.
okay. Like ultrasonogram give you a clue that uh something is there, like it may be benign, it may be malignant, but core biopsy is more appropriate. That's why they do the core biopsy, not doing the MRI of the breast. And we they have done already, they have done imaging already. So that's why like they want to confirm by doing biopsy, because biopsy is confirmatory. You got my point.
Yeah.
MRI, you can do MRI, but you can not detect that this mass is cancerous or benign lesion.
Yeah, your Wi-Fi is having an issue.
I don't know what is wrong.
Yeah, I can hear you. It's like breaking. Like I can only hear what.
You can hear now clearly.
Okay, now. Okay.
Okay, I changed the Wi-Fi. Okay,
Hmm.
now
Okay. Yeah, you were saying that they do first.
like
They first do the image.
in MRI,
Mhm,
if you do MRI, as it is an imaging, the imaging, that imaging also cannot detect that is it benign or is it malignance, because
mhm,
there may be benign breast lesion.
mhm.
So that's why do they do ultrasound guided core needle biopsy for confirmation that it is malignant. You got my point?
Okay, so why do we do the imaging then? The ultrasound or the mammogram?
We do ultrasonogram and mammogram to detect that the lesion, like
Okay,
there is a presence of a mass, there is something fishy in the breast, but
okay,
is it benign or is it malignant, you can't say. Like
okay.
there is a in fibroadenoma there is mobile mass in the but you mm, you do core needle biopsy and then you found that there are some malignant property, so this is malignancy. You got my point.
Got it. Got it.
It
Okay.
happens in lot, it happens in our country a lot. Okay.
Okay.
Okay, a 29-year-old primary gravid woman, a 29-year-old primary gravid woman comes to the primary gravid woman, 39 weeks of gestation, admitted to the hospital in labor 2 hours after the onset of contraction and spontaneous rupture of the membrane. Contraction every 2 minutes for lasts for 45 minutes. Pregnancy has been uncomplicated. Her pregnancy has been uncomplicated. She has no serious illness. Her only medication is prenatal vitamin. Pulse 110, respiration 20, blood pressure 120 by 80. Cervix is 5 centimeter dilated, 100% effaced. Cervix is 5 centimeter dilated, 100% effaced. The vertex is -2 station. Fetal heart rate tracing is shown. Labor progress. Labor progress during the next 3 hours at delivery. The newborn is limp and pale. Apgar score is 3 and 5 in 1 to 5 minutes, respectively. Which of the following is the most likely diagnosis? I don't know this.
Don't know this one. This one.
It is very new.
Okay. Ready.
Yes.
Okay. Wait, which one is it? This one. It is fetal metabolic alkalosis. Health.
Acidosis.
Oh, acidosis. Sorry. Metabolic acidosis. A healthy fetal heart rate is 110 to 120 with 6 to 25 BPM of variability and spontaneous acceleration. Intermittent early and variable decelerations can also occur during the normal process of labor as a result of head compression or umbilical cord compression. Will,
Will chop. Variable deceleration. Cord compression.
respectively. In comparison, uteroplacental insufficiency and fetal hypoxemia can present with late deceleration and fetal heart rate tracing. On fetal heart rate tracing, which are defined as gradual decreases in fetal heart rate that begin after the peak uterine contraction and nadir more than 30 seconds after the initiation of heart rate decline. Risk factors for the development of uteroplacental insufficiency are hypertension, diabetes, anemia, cocaine or tobacco use, coagulopathy, latent pregnancy, uterine infection, fetal hypoxemia can also be caused by severe uterine contraction and fetal hypotension and maternal hypotension and hypoxia. Treatment consists of supplemental oxygen, movement of the patient onto her left side or onto all four, and IV fluids. If late decelerations persist on fetal heart rate tracings, then an urgent C-section is indicated as continued uteroplacental insufficiency and fetal hypoxemia will result in deleterious effect on the fetus. This patient progressed through labor having consistent late decelerations, indicating that the fetus was probably experiencing recurrent fetal hypoxemia. and consequent fetal metabolic acidemia, which are likely responsible for this newborn presentation on delivery. How is the fetal,
Metabolic
how is the,
acidosis.
how is the metabolic acidosis happen
I don't
on
know.
the,
Is there educational objective?
oh, yeah, late deceleration are defined as gradual decrease in fetal heart beginning. Okay. These decelerations are caused by utero that results in consequent fetal hypoxemia acidemia. Risk factors. Yeah, that's all. It doesn't. Okay, let me see. How does fetal metabolic acidosis happen in late deceleration? Uteroplacental insufficiency, late deceleration, blah blah blah. We know this can happen due to various factors. We know. Uh, when uteroplacental blood flow is reduced, the amount of oxygen-rich blood reaching the fetus via the umbilical cord decreases. Hypoxemia refers to reduction of oxygen. Okay. Refers to reduction of oxygen supply to the fetus. Fetal cells normally use aerobic metabolism with oxygen and ATP to produce ATP and release CO2 and water. When oxygen supply becomes insufficient, cells are forced to switch to anaerobic metabolism. Anaerobic metabolism produces lactic acid. Okay. Okay.
Okay.
Yeah.
Next.
Next. Where am I? Right here.
A 32-year-old newly gravid woman comes to the physician for counseling prior to conception. She and her husband would like to conceive within the next year. Mens occur at regular 28 days of interval lasts for 5 days. The patient and her husband are both healthy, take medication, are in stable marital relationship, neither has tobacco, alcohol or illicit drug. She has strong family history and alcohol use disorder, and her father had Guillain-Barré syndrome. She is 170 centimeter tall, weight 80 kg, BMI 28. Her blood pressure 122 by 84. Grade is 1 by 6 systolic flow murmur. Examination show multiple diffuse nodularity of the breast, no discrete lesion. Physical examination show no abnormality. There is large verruca plantaris on the left foot. Which of the following is the most appropriate advice for this patient before conception?
Ready?
Yes.
Folic acid supplementation. Where am I? Okay, this one. Pregnancy visits allow for healthcare to provide to optimize a patient's chance to have a successful pregnancy and healthy child. The purposes of these visits should be to identify risks to the mother or fetus and to intervene where possible to decrease this risk. Typical assessment include evaluating medical conditions like obesity, diabetes, hypertension, social behaviors like drug use, exposure to teratogen and medication, genetic conditions or family history and vaccination records. Lab evaluation commonly includes rubella, varicella, serology to ensure immunity, as well as STI screening in patients at high risk, like the ones with sexual partners, multiple sexual partners, and no barrier contraception. Finally, interventions include folic acid supplementation, abstinence from drug, medication changes when needed, optimization of medical conditions, require vaccinations. Folic acid supplementation in pregnancy is critical as a Deficiency can cause neural tube defects. It is recommended for all patients planning on becoming pregnant, capable of becoming pregnant, as neural tube defects, neural tube formation occurs in the pregnancy, often before patients realize they are pregnant. The recommended dose for an affected patient is 0.4 milligrams daily. Started at least one more prior to where am I? To pregnancy. Patients who have had previous child with a neural tube defect or have a family history of neural tube defect should take 1 to 4 milligrams of folic acid daily, starting 1 to 3 months prior to conception. I was between another one. Mammography is not warranted in this patient. Mammography is typically recommended in the setting of palpable breast mass, which this patient does not have, or as a screening modality after 40 years of age. Removal of verruca plantaris is not necessary prior to conception. While it may be offered, it will not affect the patient's ability to become pregnant, nor the pregnancy itself.
Okay.
Mhm.
If a previously healthy 72-year-old woman comes to the physician because of 3-week history of vulvar itching and discomfort despite treatment with over-the-counter or this antifungal drug, she is sexually active with one partner. Family history shows 1 centimeter small firm left inguinal lymph node. Physical pelvic examination show mild edema, excoriation over the labia majora and minora. There is 1 centimeter tender raised lesion, ulcerated center, and erythematous edges at the base of the labia major, cervix, vaginal mucosa, uterus, adnection normal. There is wide discharge with no odor in the vaginal canal. Which of the following is the most likely diagnosis? Okay.
Moment. Tender Rex region, cervix. Is it vulvar cancer or is it herpes? Sexually active with one lingering and pelvic exam excoriations. Maria Manora. Standard. I don't know. Is it herpes or is it okay? I'll go with that. Mm,
Ready?
7. Yep. Okay, so it's vulvar cancer. Vulvar carcinoma most commonly presents with in older patients with a lesion on the labia majora that is often asymptomatic. The lesion may be a nodule, papule, or plaque with varying degrees of ulceration. When present, other symptoms include pruritus or bleeding from the lesion. In addition to the lesion, physical exam may show inguinal lymphadenopathy as seen in this patient. If the vulvar cancer has metastasized, the most frequent underlying histopathology is squamous cell carcinoma. Okay, and incidence is greater in patients that are 55 to 85 years old. Risk factors include infection with HPV, cigarette smoking, immunosuppression, chronic inflammation like lichen sclerosis, and a history of cervical cancer. Diagnosis is made with biopsy of the lesion. Further evaluation should include cervical cancer screening, and concurrent cervical carcinoma is common. Abdominopelvic imaging to determine the extent of disease. Treatment includes surgical resection and chemoradiation. It's not B. Herpes simplex genital infection is most commonly caused by HSV2, characterized by painful vesicles in the genital area like vulva, vagina, cervix, perineum. Infection typically begins with the formation of vesicle which lies and progresses to shallow, painful ulcers with a red border. A single pruritic raised lesion will be unlikely. Okay.
Next. An 11-year-old girl is brought to the physician by her mother is concerned that her daughter is maturing. Her daughter is maturing too early. She reports that her daughter had breast and pubic and axillary hair growth. Her daughter has pubic and axillary hair growth during the past 6 months. She has had the onset of first menstrual period 2 weeks ago. The mother adds that none of her daughter's friends have been begun their menses. The patient is at 75 percentile height and 75 percentile height, 50 percentile weight BMI. Breast and pubic hair development in sexual maturity training is maturity rating is stage 4. Physical examination normal, which of the following is the most likely diagnosis?
Ready?
Isn't it thelarche?
I I don't know. I didn't pick that.
Okay, or adrenarche. Oh,
Ready? Oh,
yes, yes.
normal development. Puberty in girls follows a predictable course of boobs, boobs, uh, boobs, pubes, and whatever. Uh, Telarchy is breast development, so telarchy titties, followed by pubarchy, which is pubic hair growth and growth spurt, and finally by menarche, which is menopause, menstruation. Puberty is considered delay in girls if breast development does not occur by age 12 to 13 years old. Breast 12 to 13. This patient is 11 old and has had a normal sequence of pubertal development with telarchy, pubarchy, and yeah, and menarche. The most likely diagnosis is normal development. It's not precocious puberty. Uh, here. Precocious puberty is the onset of pubertal development and sexual secondary characteristic before 18 girls. It can be central or peripheral. Central precocious puberty is caused by activation of hypothalamic pituitary gonadal axis with increased FSH and LH concentration. This early activation can be idiopathic or caused by central CNS abnormalities such as brain tumor. Peripheral precocious puberty is caused by release of excess sex hormone from the gonads or adrenal gland, or potentially in the ectopic production of ACG from a germ cell tumor. FSH and LH are decreased. Okay, next.
A 27-year-old primary gravid woman at 10 weeks of gestation comes to the physician for the first prenatal visit. She feels well. Her pregnancy has been uncomplicated. Examination show uterus consistent in size. 10 weeks of gestation. A pap show high grade squamous intraepithelial lesion. High grade in squamous intraepithelial lesion. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
Please perform colposcopy with biopsy if indicated. Carcinoma of the cervix is classically associated with HPV high risk strains 16, 18, 31, 33. These factors include multiple sexual partners, smoking, immunosuppression. Cervical cancer screening with pap smear is recommended every 3 years from women 29, 21 to 29, and 5 years with HPV co-testing for women 30 to 65. The results of this screening test then determine the need for further evaluation and diagnosis. The cervical cytology results may be normal, indeterminate, or show signs of atypical squamous cells of indeterminate cell or precancerous lesions, low or high grade intraepithelial lesions. High grade squamous Intraepithelial lesion has an increased risk of progression to cancer. Abnormal pap smear results are evaluated by colposcopy, which allows for visual assessment and biopsy of abnormal lesions, and is the most appropriate next step. High-grade lesions and cervical cytology may be treated with excision via lip procedure or cum biopsy of the cervix, but this is not recommended for pregnant patients, as it may lead to complications such as cervical insufficiency and patent liver. It is not safe. Administer HPV vaccine is not warranted. Administration of HPV vaccine is recommended for patients up to age 26. In addition, this patient already has sign of HPV cervical changes, making the vaccination unlikely to have a benefit. Okay, next.
A 1900-gram newborn was newborn has generalized lymphadenopathy. On examination, she was delivered at she was delivered at term to a 25-year-old primary gravid woman. Pregnancy and delivery was uncomplicated. The head circumference is below the fifth percentile for the gestational age. Her temperature is 37 degrees Celsius, pulse 150 per minute, respiration 40 per minute. Fundoscopy examination shows chorioretinitis. Chorioretinitis, liver age is 4 centimeter, palpated below the right costal margin. Spleen is 2 centimeter below the left costal margin. Serum studies show AST activity is 247, ALT is 196, ACT scan intracranial intracerebral calcification. Which of the following intrauterine organism is most likely cause?
Ready?
Yes.
So, cytomegalovirus CMV infection is asymptomatic at birth in approximately like 90% of newborns. When symptomatic in utero, ultrasound may show hepatosplenomegaly, intrauterine growth restriction, microcephaly, intracerebral, most often periventricular calcification, fetal high drops is a potential complication. Clinical features in symptomatic newborn include the above, as well as transaminitis, jaundice, thrombocytopenia, petechia, chorioretinitis, small baby seizures, and sensorineural hearing loss. Long-term sequelae in symptomatic infants, such as sensorineural hearing loss and neurodevelopmental abnormalities, are common. Okay. The risk for symptomatic neonatal infection is higher with the primary maternal infection than with the recurrent infection. In adult CMV, it's often asymptomatic or can cause a short febrile flu-like illness. Congenital CMV is the most common cause of non-hereditary sensorineural hearing loss and can present later in childhood in up to 10% of children who are asymptomatic at birth. Diagnosis of neonatal CMV can be confirmed with PCR testing or culture of urine or saliva. Treatment involves 6 months of oral valganciclovir and close interdisciplinary follow-up. Next.
Next,
Mhm.
a 52-year-old woman for a routine health maintenance examination, occasional vaginal spotting for past 2 months, over 2 months. She has not had hot flashes, vaginal dryness, has been relieved by black cosh, a natural food supplement. She also used ginseng to root tea daily. Her menstrual period was 2 years ago. Examination shows no abnormality. In addition to the pap smear and mammography, which of the following is the appropriate next step in the diagnosis?
Ready?
Yes.
Okay. So it's endometrial biopsy. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, or not associated with signs of menstruation. It may be caused by malignancy, structural abnormalities, um, such as cervical endometrial polyps, adenomyosis, endometrial hyperplasia, inflammation, infection of the coagulopathy, ovulatory dysfunction, endocrine issues. It may be idiopathic. In patients over 45 who are perimenopausal or postmenopausal, there is a higher risk of endometrial cancer. Endometrial cancer commonly presents with postmenopausal vaginal bleeding, as seen in this patient. Risk factors include prolonged unopposed estrogen, such as early menarche, late menopause, chronic anovulation like PCOS, exogenous estrogen therapy, obesity, nulliparity. The most appropriate next step in evaluation of this patient is endometrial biopsy to evaluate for presence of endometrial cancer. If a patient cannot tolerate the procedure or if the procedure sampling is not diagnostic, eye dilation and curettage or hysteroscopy can be performed. It is not C. Toxicology screening is not necessary in the diagnosis of postmenopausal bleeding. While cocaine and amphetamine use may be associated with vaginal bleeding during pregnancy secondary to placental adoption, these substances are other toxins do not routinely cause vaginal spotting in postmenopausal women. Okay, next.
Yes.
Oh, oh,
Where is 50?
we don't have 50. Never mind.
There is 50. Okay. There is
What
no
is?
question, but there is answer. Okay, I am
Oh,
reading the
okay.
question and you read the answer.
Oh, the question is here. Sorry.
You found the question?
I mean, in the answer choice. Sorry.
Yes, yes,
Okay.
that's what
So,
I'm talking about.
yeah, go ahead.
A 16-year-old patient, Gravida 1, Para 1, has increasingly severe pelvic pain, feels cold one day after emergency cesarean delivery at term for non-reassuring fetal testing. She has spontaneous rupture of the membrane at 3 am. Prophylactic antibiotics were administered prior to the incision. The caesarean section was performed under general anesthesia, lasted 40 minutes. She delivered 4.4 kg newborn at 11 p.m. She is lying in bed under several blankets. Her temperature is 102, pulse 129, respiration 16, blood pressure 110 by 70, uterus is tender to palpation. The incision site is clean and dry. There is no erythema. Which of the following is the strongest predisposing factor in this patient's condition? Okay, what is your diagnosis?
Mm, I don't. I don't know. That could either endometritis or whatever, something like that.
Yes, you have told yesterday. Like if it is within the, like before delivery, like during delivery, it is chorioamnionitis if associated with fever, and if it is after delivery, it may be endometritis, isn't
Mm-hmm.
it? You have said.
Mm-hmm.
Okay, so
But
it is after delivery.
yeah, but they're not asking for the diagnosis here. So the and they're saying that the answer is from rupture of membranes to delivery. But she ruptured the membranes at 3 a.m. and delivered at 11 a.m. So it was like how many hours?
Prolonged
More than
labor,
18. Prolonged labor is how many hours?
18 years, 18 hours.
Okay, so 3 to 11 is 18 hours. It's more than 18 hours. Okay.
Okay, I'm reading the explanation. A recent postpartum patient with fever and uterine tenderness. A recent postpartum patient with the fever and uterine tenderness choices suspicion of endometritis, especially in the setting of prolonged rupture of the membrane, time from rupture of the membrane to the delivery. Postpartum endometritis. Postpartum endometritis is acute, typically polymicrobial infection of the uterine endometrium involving a mixture of aerobes and anaerobes from the genital tract during labor and delivery. Microbes from the genital tract can enter the uterine cavity and can result in postpartum infection. Patients typically present with high fever, tenderness, and uterine fundus and mucopurulent vaginal discharge. Risk factor for endometritis include premature or prolonged rupture of the membrane, prolonged labor, cesarean delivery, bacterial vaginosis, obstetrical colonization, manual removal of the placenta. Treatment requires broad-spectrum antibiotics, clindamycin and gentamicin for appropriate antimicrobial coverage. Okay.
Okay. Yeah, done now.